STFM's third webinar on precepting and teaching physician. My name is Tom Van Sagi, and I'm STFM's Director of Online Education. Over the next 4 webinar sessions, we'll cover topics and challenges that preceptors face and demonstrate an innovative web resource, Teaching Physician, which is available at teachingphysician.org. Today's webinar is titled Providing Feedback to Students and Residents and will be led by Dr. Randy Clinch from Wake Forest School of Medicine. Dr. Clinch is on the line. Would you like to introduce yourself?
Sure, Tom, thanks. So I'm a practicing family physician here at Wake Forest University School of Medicine, and I am also the Family Medicine Clerkship Director here, so that's pertinent to our discussion. I teach residents in our residency program and sports medicine fellows as well. And one of my hats at the medical school is that I'm the Associate Dean for Accreditation, and that means I interface with the standards for the LCME with our medical school. And I'll speak to how the Teaching Physician site can help institutions with their accreditation issues as well.
Great. Thanks, Dr. Clinch. I know you have a very exciting and dynamic presentation in store. The webinar today will focus on how you as a preceptor can provide constructive feedback to your students and your residents, and how the Teaching Physician web resource can help you with that. At the conclusion of the webinar, we'll be happy to take questions, but I know if you have them throughout, I know that Randy will be happy to stop and answer those as well. We are recording our webinar today, and it will be available on the STFM website, which is accessible at www.stfm.org. Just scroll to the bottom of the home page, and you'll find the Teaching Physician Webinar Series link, which will take you to a complete inventory of the webinars in this series. In addition, this is the first of the webinar series where we are offering 1 credit of the CME, Continuing Medical Education credit. At the end of the webinar, within 24 hours, you should get a survey which you can take and tell us how we did with delivering this webinar. At the end of the survey is a link that will take you to a self-reporting page at the AAFP site where you can claim your CME credit. You'll also be able to do that accessing the STFM website, as I just mentioned a little bit ago, www.stfm.org. With that, let's go ahead. Randy, go ahead and tell us about today's webinar.
All right, thanks a lot, Tom. So one of my motivators for wanting to do this webinar and even to have this whole series available is that there's a rich amount of material available on the Teaching Physician website. We've been using it here at Wake Forest for about 2 years, and like any resource, there is a lot of information on it. But as anyone who's ever browsed different websites and web pages knows, there's a bit of a learning curve to feeling comfortable accessing the resource, knowing what's there, knowing how to apply it. So today we're going to cover both the topic of providing feedback and get some specifics about that, and do a bit of a guided tour on the section on the Teaching Physician that deals with feedback. So little by little, the webinars will make you familiar with Teaching Physician and what's available there so that you can have some point-of-care resources and enhance your ability to provide effective feedback, among other things. So we have the learning objectives listed for today, but mainly I'd like to basically equip you with a way of thinking about feedback and to give you tools to deliver effective feedback. So part of the learning objectives are the characteristics, describing the techniques, and specifically, where can you find this information on the web later on when the webinar is done and you want a quick access to things. So since we're in a webinar format and I can't see you raising your hands, I'd like to see if we can get a poll open. I've got 2 quick polls so I can get to know my audience a little bit better. So what I'm going to do now is just kind of open one of the polls, and you'll see basically this screen, the poll screen, and just take a couple seconds to answer the quick questions on there, and then I'll tell you what the answers look like. So I should have just launched a quick poll, and basically just try to figure out who is your audience. Primarily, do you teach medical students, primarily residents, faculty development? Do you do grad students or PA students, for example, or maybe you're administrative? and you don't do the feedback. But just kind of pick your primary feedback audience if you can. I'll give it just a couple more seconds to stay open. All right, so I'm going to close that, and it looks like what I can see is we've got about 32% of the folks primarily teach medical students, about 48% teach residents, and about 20% say their primary feedback audience would be faculty. Okay, so that's helpful for me to know. And then the other poll I'd like to kind of look at and quickly get your input on is I do some mentoring instructions across the generations, and how we mentor and sometimes how we give feedback varies based upon our generation. So just to get a sense of the audience here. Now keep that open a little bit. It is very interesting, and maybe that could be a topic of a subsequent session or a webinar just about mentoring across the generations, particularly for our residency faculty. All right, let me go ahead and close that. So it appears that the largest percentage is the baby boomers. We've got 56%, and I'm in that category as well. We've got 41% of folks in Generation X, and we've got 4% of the millennials, so the Generation Y. And typically, and I was thinking about this before, if you have someone who's gone basically straight through college, straight through medical school, through residency, and is out now in a faculty position, that's why we're seeing maybe about 4% of our audience in the millennial generation. So, so welcome. So that helps me know a little bit about my audience and who's involved here. So basically, as Tom mentioned, as we're done with this, you should be able to get some CME credit for this topic, and it'll be available for viewing afterwards. So the format that I'm going to take now is shifting gears a little bit from the standard PowerPoint slides because I want to give you a message for your mind and an image for your heart to make these ideas about feedback and these tools stick with you. When you are done, you will have the archived review of this webinar, and depending upon if your institution offers a subscription to Teaching Physician, you may be able to log in, and that's what I'll show you on this guided tour to the Teaching Physician website for some review. So we start with feedback, and that was chosen as the very first session because it's one of the most requested topics by faculty whenever we discuss a needs assessment for faculty development topics. Giving feedback is typically the #1 requested topic. Same with residents. When we talk about residents as teachers, they want to know how to give feedback. Most of us as individuals are not filled with a sense of joy and rapture when someone says, I need to give you some feedback. And I think it's because mostly we feel uncomfortable pointing out some of the things that a person needs to change. We want them to like us. We want them to feel good about their skills. But I really want to stress as we go through here your importance in your role in providing feedback to help shape the development of your learners, both residents and medical students, and to make sure that you have access to those tools and techniques to provide more effective feedback. So what is feedback, just in general? Well, I want to read the definition of it briefly. It's the process in which part of the output of a system is returned to its input in order to regulate its further output. So basically, I want to make sure you have techniques to help your learners hit their target and to avoid dropping bombs on your learners in terms of feedback. So feedback isn't rocket science, but it does come from rocketry. So imagine if you're the engineer sitting there in mission control and you've just launched a rocket, and the rocket is heading off to its target somewhere in space. Well, you need to know how fast the rocket is going and its trajectory, and it needs to send you this information. And in rocketry, they determine the word to be feedback because the engineer took that information from the rocket, fed it back to the rocket to make course corrections as it's leading towards its target. So we've used the idea of feedback in medical education similarly, and I want to kind of just expand upon that idea in general. So rockets, again, is a message for your mind, an image for your heart. You need to know specific details if you're going to try to reach a target. So you need to know what's the location of my target, the distance, is there anything in my path that I need to know to get my rocket there? We have to give the rocket a way of providing us information while it's in flight so we can feed that back and change the course. We analyze that information, We make those constant course adjustments. A lot of times we're off course most of the time, and we're making constant adjustments until it reaches its target. And it takes a lot of work to launch and successfully navigate a target, so it's usually one that we're dealing with, one that we want to prepare very well. So we put a lot of time and effort into it. Now, bombs, on the other hand, it doesn't take a lot to make a bomb. You can probably Google search how to make a bomb. And you just basically need to know the general location of your target, and you kind of hope that you can hit your target, and most of the time you just throw a bunch of bombs at it. So, when it comes to giving effective feedback to our learners and students, we just don't want to be the person dropping a lot of bombs on them. So we'll go over some of these techniques to avoid that situation. So let's think about, in general, the comparison between rockets and learners. So we have this sense of rockets. So, you need to know the target. What does that mean? Well, from a learner's perspective, our resident or our medical students, we need to know their goals and objectives and that of their institution. So if they're from outside or they're on a different elective, you need to know the goals of that elective and of your learner for that day. The ability to send information while in flight, well, we have to arrange the learning experience in our office, in the hospital setting, so that we can directly observe our learner. Direct observation, the information we get from that's going to be the topic of the next webinar, but that's the way that you can take that information and feed it back to the person to allow them to change their behaviors. So you're analyzing the information in your rocket. Same thing, you need to determine what the learner is doing well, what needs to be modified, and how to provide that feedback. And just like the engineer is ultimately responsible for the rocket reaching its target, our feedback and guidance will help the learner advance and become a caring, competent professional, resident, medical student, PA student, you name it. So that's how I like to think about the similarities between the learners and our rockets. This is one of my favorite quotations: "The sky is filled with stars, invisible by day." And it basically reminds me that we have to be constantly observing our learners, constantly looking at their skills and behaviors, or we're going to miss the opportunity to be effective. Yes, we want to give them praise. Yes, we have to give them criticism, which is a judgment of something, so that's part of our role. But a huge part of our role is balancing the delivery of that sort of praise with criticism and giving them next steps, so the guidance that gives them direction or advice as to their course of action. That's where we come in. That's what they're hoping to get from us, because we're the professional that can give them that guidance based upon our experience. So we look for both things, praise and criticism. And if you think about it, our students, unlike rockets, do not have guidance systems built into them. They aren't necessarily set up with past experiences that might have been good, bad, or ugly with respect to getting feedback. So they're not automatically ready to receive the feedback. Sometimes they're asking for general reassurance that they're doing well. But we have to give them very specifics, and we have to figure out a way to do that. And some of the techniques we'll cover today goes over that. So I want to point out a very elegant little study that was done and reported on in 2006. So there was a group that did a study on students tying surgical knots. And half of the group of students were randomized to receive just praise feedback, and the other half got very specific procedure-related feedback. So the group was taught, the entire group was taught by a well-respected surgeon who gave them instructions about tying knots and how to do that appropriately. And then the students were allowed to perform their knots and get everything done as best they could, and the surgeon went around and gave them feedback. So the group that got praise feedback just heard things like, very good knot, nice looking knot, way to go. And then the group that got the procedure-specific feedback heard things like, you need to cut the ends of your knots about 1/8 of an inch, or you threw 3 loops around that knot, next time you need to throw 4. So they got very specific feedback. So what did the students like? Well, they rated the praise feedback as higher quality than the focused feedback on their specific skills. Now, all the students then repeated their knot tying exercise, and then they had their knots assessed for the quality of those knots, and basically it was only the folks that received the focus feedback that had improved performance. The folks that received the praise did not. So they didn't know what to improve, how to improve, anything like that. So the bottom line from this study actually was that student satisfaction with feedback is not very accurate of a measure of the quality of the feedback. How does that apply to us? We often poll our students at the end of experiences as to how they felt their sessions went, the feedback went. We seek that input from them, and we want that, and we don't want to discount it, but we have to recognize that if they are describing the quality of the feedback, it may be up to us to make sure we're giving them very specific feedback that can move them forward professionally and with competency. And if they specifically say, I just didn't like that as much as maybe some other feedback, realize that it may be that we're not providing them some praise and balancing that with the guidance. So we have to give both, but if we just give praise, you can see, at least in this elegant little study, that those folks didn't move forward. They didn't demonstrate any competency or improve things like the ones that received the specific feedback. So this is one way I like to have you think about characteristics of effective feedback. So this is, you don't have to remember all of this, but I like putting things together to kind of take a little chunk and hold on to it. So T time is the way I like to think about giving feedback. So the T time is timely, effective, and empathic. And timely, it should be close to the learning event. So if you're working with a student that morning or that afternoon, sometime during that day or that session, go ahead and see if you can give them some feedback. If you're working with them on a longer rotation, try to give it to them in brief segments and not at the very end of the experience, not days and days later. So timely, close to the learning event. Effective, so these are characteristics that we'll talk about, but being very specific, as we just talked about in the knot tying experiment, is more effective than being very general. I think a lot of people providing feedback don't have the repertoire of specific statements that they might pull out and give to the students. They might use the generalities like, you need to read more and expand your differential diagnosis. So the question is, who doesn't, right? So if you get that as a learner, you're going to say, well, okay, but how does that help me move forward after this learning session we just had? So being very specific. I often say that my surgical colleagues, when they're dealing with technical feedback, have a better time, a more appropriate time giving feedback because they can comment on, you cut that too long, you cut that too short, place your hand here, hold the knife this way. Very timely, very specific, very behavior oriented. When you deal with things like interpersonal skills, communication skills, plan management skills and discussions, those are different. Those are our techniques, but those are different, and we have to be observant for how to be specific to the student about those aspects as well. This statement, based upon your direct observation to be effective, again, it's going to be the topic of the next webinar, but imagine if you were the tennis coach and told your player to go knock the ball around for a while and you'll hang out in the clubhouse, and then afterwards the tennis player comes back and they tell you how they thought their serve went or their volleys went and that sort of thing. So I just want to raise the idea that the vast majority, at least with medical students and potentially even more with residents in an outpatient setting, the vast majority of the time our learners may be in the room with the patient by themselves. If there is no video camera going on, if you're not in the room for a portion of them doing things, when they come out and present to us, some of what we do is extrapolate what went on and how we think their medical knowledge base is and their history gathering skills are. But if we didn't see them in action, we can't give them very specific feedback about their performance. So we'll talk again about next time how to interact and weave in direct observation during a busy precepting session. And we'll talk about the use of the modified feedback sandwich. We'll go over that in a minute. And then finally, feedback has to be empathic. So we should ask our learners for their own assessment of their performance. Oftentimes they are more critical of their own performance than we are, and that's okay. But if they say, no, I think I did great, I knocked the ball out of the park, and you say, oh, there are some things that I've noticed about this learner, maybe they're just not aware of their performance issues. So definitely get a self-assessment. Focusing on things the learner can control is always a key issue. Our learners can control the tone of their voice and the volume at which they're speaking. They may not be able to control the quality of their voice, for example, if it's a very nasal quality or something that to you sounds a little bit difficult to deal with. You may have to give them feedback on speaking loud enough for elderly patients, if that's the case, or slow enough if they speak quickly. But those are things the learner can control, and there's a lot of things they can control, but focus on those things that they are able to control. Confirming understanding at the end of your feedback to make sure that you know your learner is able to put this into practice, move forward, and try differently next time. So think of tea time when you're going to give a feedback session, and we'll kind of review these things. You'll see similar statements when we go to the teaching physician website, and this is just one way to pull all those things together. So the feedback sandwich, I think a lot of folks have heard about this topic. If residents are watching this video as part of a resident as teacher program, this might be the first time they hear about it, but you've probably been the recipient of a feedback sandwich. So typically the meat is the negative feedback and is sandwiched between a couple positive statements. So it's easier to hear when you start off with a positive. So as an example, the history that you just took about that patient's chest pain was complete. The review of systems was nice and focused on the pertinent positives and negatives. And then you typically give something that you'd like to see changed. So you listened to that person's heart in 2 areas and on top of their shirt. And then sometimes you would follow it up with another positive statement like, I think you did a good job writing their prescription. So those are statements, that's basically information, and that's the feedback. What I like to do is change it and suggest a modified feedback sandwich where you do begin with a positive feedback statement, because that is easier to hear once you initiate your discussion. You come up with your statement about what you'd like to see the learner modify, so that's the negative feedback, and we'll go over how to introduce those topics. But then you end with something that is an action item. So you tell them your recommendation, your guidance about what the learner can do differently next time so that they more closely hit the target that they're striving for. So similarly, your chest pain history was nice and accurate and complete. Your review of systems was focused on the pertinent cardiovascular aspects for this patient. You listened to the heart on the patient's shirt and in 2 areas, and the recommendation next time, what I would recommend you do in order to fully listen to the patient's heart would be to listen directly on the skin and to listen in the 4 valve areas and to palpate their point of maximal intensity. So that gives them something to do differently next time. And there's a variety of variations on the theme, but I think if we just stop at giving them a positive feedback in the feedback sandwich, we don't give them something to do so that they can move forward for next time. So before we move on to the guided tour of the teaching physician website, I want to give you some specifics about how to deliver your feedback. Because again, it's something that a lot of people feel uncomfortable with, and a lot of the delivery of the feedback makes sure that you understand the goals that the person's aiming for, and that you have some interpersonal skills and a set of phrases that you can pull out and deliver. So basically being very direct. The first sentence, identify the topic or the issue that you'll address. So you're done with your morning session with the student and you say, let's talk about how you did today in clinic. So very, that's kind of what you're going to go over. Or even more specifically, let's talk about that cardiac patient's evaluation. So just bring it up. First sentence, what's the topic, what's the issue? Instead of starting with you statements, you need to do this, or you did this. Start with the I statements. So again, this is that interpersonal skill set that allows the person to hear you better. They feel less threatened. So I have noticed that when you take a history, you seem to be very appropriate, very accurate, very focused on the problem at hand. I've observed, and then you can go into other things. So the same thing, just what you have done. It works for positive feedback, things they're doing well that you'd like to see them continue to do well. It works for negative feedback. I've observed that every time you do the cardiac exam, you listen in 2 areas and you listen on the shirt. And then sometimes if you happen to be a clerkship director or in an administrative position where you get feedback from other people, and you didn't directly observe things or work with the learner, you may have to start off with, I've had reported to me, and then you describe what the other people have given you data on the evaluations about the learner. So that's just a way to start the discussion. Being very direct in delivering the message. So sometimes what happens in the initial discussion of feedback is that we try to soften the feedback by being indirect. And maybe we'll start off with statements such as, you know, a lot of students, and then you go into what maybe a lot of students experience. Or you start discussing things that, you know, maybe this person has done before, but you're not being specific about the evaluation and the performance of the visit for today. So be very direct in delivering your message. State your observations, not your interpretations. So a person who hears something like, you know, that was an incomplete cardiac exam. So you know what you mean by that. They might not. That's an interpretation of their performance. You can observe and state you listened in 2 areas of the heart and you listened over the shirt. So that's an observation, not an interpretation. Hopefully people wouldn't give feedback that is couched in the way of, this is the worst abdominal exam I've ever seen. You know, again, that doesn't give the person a specific thing to work on. They don't know exactly why you have judged it or interpreted it to be the worst that you've seen. So state observations, not interpretations. Avoiding certain phrases. So if you start with, you need to do this, it changes the tone of the feedback session. So again, if you're able to give them specifics, be direct, and then tell them what you'd like to see done differently so that they can reach their goal next time, and avoid some of the you need to phrases, they'll receive it better. The but statement, the yes but. So if you initiate your discussion and you say, you did a good job taking the history, it was very accurate, your review of systems was complete, but your cardiac exam, and then you go on, the but oftentimes negates the praise feedback that you just delivered. And if you'd like to see those behaviors continued, you may have just washed that out of the person's mind because they heard the but or the however. So you'd like to avoid those. A better way of phrasing it would be something like the praise feedback about their history and review of systems, and then you can begin to address the negative feedback by saying, and now let's discuss your cardiac exam. So the and phrases are better connectors than the yes but or the however phrases. So these again are just techniques and skills and interpersonal communication skills that relate to delivering feedback. It works for residents, it works for students, and if you happen to have other personnel that you work with, maybe you have to deliver annual performance evaluations or quarterly performance evaluations in a human resources type setting, this is the same kind of approach that you can deliver to anyone receiving any sort of feedback. It doesn't have to be clinical feedback. And finally, if you are delivering the negative feedback, so this is something that you'd like to see changed differently next time, express your concern. So say, for example, we continue with the you listened in 2 places on the heart and you listened on the shirt. You can give them your concern. So I'm concerned that you're not going to get a complete cardiac exam and some of the sounds may be muffled if you listen over the shirt. So next time, and then you go on and describe what you'd like to see done next time. You avoid tones. This is controlling our interpersonal communication skills. You avoid those anger and frustration tones or sarcastic tones because that does change the message. The person is less likely to receive your feedback well, and then potentially, just like a patient, less likely to implement your recommendations. So let's take a look at some of the resources that are available on the teachingphysician.org website. I've listed here the different sections, and we'll briefly go through them on a bit of a guided tour. So the feedback section itself has information that addresses the sandwich model that we talked about, some teaching skills, levels of feedback we'll go over, mid-rotation, and then there's a variety of wonderful things, including videos. If you've never seen this, there are nice video snippet examples that you can pull up, you can review on your own, you can get other faculty members together and discuss how you would do it. And then specifically for residency programs, there are 3 modules, and one of them is feedback for learners that goes over topics that might be specific to teaching residents, and you can get additional CME credit for those modules. So I'm going to go out to I'm already logged in on the Teaching Physician website. So what you should be seeing now is the live website of Teaching Physician. And you'll see the preceptor resources up here is the first tab that shows up when you log in. And there are a variety of other topics that are underneath here: teaching strategies, giving feedback, which is what we'll talk about today. These boot camp modules, which I'll briefly address, that's the residency modules that I just talked about. So you can get to the giving feedback section through this tab up here, or the link is active down below where it says giving feedback. So either one you can click on, and it'll take you to this giving feedback section. The website is set up the same way basically across the pages, so as a bit of a guided tour, once you get used to how the website is set up, you'll be able to then explore the content in the other areas. So in this giving feedback section, there is a little video which I will not play because I'm not sure how it'll work on everybody's web browsers. But it's an example of a student who's performing an exam, and then his preceptor is observing and gives him some corrective feedback and pointers. So again, you can watch some of these videos and decide, would I address this way? Might I change it in some other fashion? And you can get you and your colleagues to decide if this would be an example of the best way to do something, or would you tweak it or adjust it a little bit. If you can see in the center column here under giving feedback, after this webinar, if you want to review the archived webinar, great. But there might be a chance where you just need to briefly review some pointers and tips about feedback. And this is the place to go. So if you say, I'm working with a student later today or tomorrow, and we covered a lot of details, we had a lot of good discussion, but I just want the nuggets of things. So this is where to go to get those quick tips. And you'll see the topics listed in here, like give positive comments first. Limit things to what the student can use. Make sure you're being understood. Link it to their goals. So these are all the same kind of topics that we just discussed, and it's just in one little place for you. And if you look over here, I want to click on a resource, How to Be an Efficient and Effective Preceptor. These resources will open in a new window, so you won't lose where you are. And it's typically an article, or you'll see down here one of my colleagues has put together a PowerPoint presentation, presented at one of the STFM meetings, and so that actual PowerPoint presentation is available for you. And then at the very bottom, this links you to that Resident Bootcamp module, which would start this interactive CME module about feedback. But if you look at the link here, it should pop open pretty quickly to one of the articles about giving feedback, How to Be an Effective and Efficient Preceptor. So this was something from Family Practice Management, and you can scroll down and easily read through this. It's not as quick as the little tips that are listed on the feedback site, but if you want additional information, as you can see, there's plenty of resources available, and sometimes just knowing what's available is important. So this isn't the only video for feedback. We'll see a few other ones, and there's a link to what's available in the ever-growing video library. And I think that's a wonderful resource here for Teaching Physician, because in a variety of institutions we always say, well, I wish I just had an example of someone doing this way, or if I had an example of a good or a bad learner doing this behavior. So look at some of those videos and see if they will help you out. The link over to the left will jump to the different sections within the giving feedback, and just like we talked about with that sandwich model, this is just the brief little summary of the sandwich model. It's the bread and the meat, the positive feedback, sandwiched with the negative feedback, making sure it's genuine, not using the word but between the statements. So, and now let's talk about your cardiac exam, not but your cardiac exam needs to be improved, right? So it's a different way of receiving things. And as it says in the bottom, it's not always necessary to sandwich criticism with praise. I would prefer that modified approach where you give the person what to do next time so that they can more closely approach the target that they're aiming at. I love this video off to the right. It's a great example of a faculty member or a preceptor giving a student that sandwich method of her recent performance about some health maintenance issues and counseling issues. And it's just a real brief example, but it's one of the best ones I've seen. So the same resources are listed here. There are a variety of things about problem feedback, difficult learners, giving and receiving. Here's that same PowerPoint presentation. So you can see there's a lot of resources at your disposal. The next section, just briefly to mention, the 5-step micro skills. You may have heard about this. It's called the 1-minute preceptor or the 5-step micro skills. This page, again, just gives you the very brief. If you say, oh, I heard about that, but I don't have time to read about it too much. I just want to remember what they are. Oh, yeah, it's get a commitment is the first one. Probe for supporting evidence. Teach general rules. Reinforce what was done right and correct mistakes. So this is a technique, and it's very, very user-friendly. Most faculty members, once they learn and apply this technique, can remember and apply the technique long after they've learned about it. So it really turns your the small amount of teaching time that you might have and you want to do with a clinical learner into something very structured and very useful. And again, this is another article. It'll just link out to that page, and it goes over a little more detail about how to apply this concept that's been around since 1992, the 1-minute preceptor, the micro skills of teaching. So that's basically, if you haven't heard of it, definitely read up on it. If you're a resident for the first time dealing with how to teach students, definitely read up on this. I know for accreditation purposes, residents have a whole lot of requirements on their ACGME for doing some teaching, so this really helps them out. And so again, this is a longer video. If you guys are viewing this afterwards, it's a longer video going over applying the 5-step micro skills. It may or may not be exactly the way you would do it, since there's a lot of individuality in how you apply these skills, but you can look at the video and decide if that's the way you want to go. And again, just get a group of faculty together if you want, talk about it, just view it on your own and see what you would change. So I like mentioning this. This is really a teaching technique, but the last two things, reinforce what was done right and correcting mistakes, all revolve around you giving feedback to this person. And how do you give feedback, like we're discussing, that is going to be more effective, received better, and hopefully applied by the learner better. So the last two things here on this section is something called feedback levels. I don't care if you remember the specific what is a level, but just remember that there are different ways for someone that you're working with to accept the feedback you're giving. If you have just met this learner, or you don't have a long-standing relationship with the learner, they're not sure about how safe it is to receive feedback from you, maybe the institution doesn't have this culture of feedback readily available, and people are just kind of worried about feedback. The easiest feedback to provide someone is just like being a human video recorder. So you basically are observing what's going on, and you're playing back exactly what you saw. So for example, if you saw the person listen to their heart on the shirt or through a coat or something like that, that's what you say. Basically, you start off your feedback. If you do notice something positive, use the sandwich, say, hey, your history about that chest pain was complete and accurate. I noticed that you listened to the heart on this shirt. And that's basically a fact. It's not a judgment. It's something that the learner can't argue with. So if you're a learner who is unsure of how safe this person's feedback is going to be, you can receive that because they basically just played back what they saw. So it's not an arguable point, right? So then if you have to deliver negative feedback about what you saw, the next level is dealing with your concerns, your emotional response, what you felt. And basically I recommend just using the word concern. So if you have a problem, if you have a concern, if you notice something you'd like to see changed differently, use the word concern. So let's change it up a little bit and talk about an abdominal exam. So the patient with abdominal pain, the student came in, did the exam, the patient's pain was in the right lower quadrant, and they started right off in the right lower quadrant, pushing deeply, feeling for the area of the pain. right? So if you say, I noticed that when you started your abdominal exam, you started the exam right in the area where they had most of their pain. And then you can deliver the level 2, which is your concern. I'm concerned if you start an exam right where they have the majority of their pain, you're going to get not as good of an exam, and the patient will be more guarded. They'll be uncomfortable with you performing the rest of the exam. And then level 3 goes one step further, where you give them that guidance and your prediction based upon your years of experience. So you can state something like, in my experience, if you tend to start your abdominal exam right where the patient hurts, you're less likely going to get a thorough exam because they aren't going to allow you to do the rest of the exam comfortably. So just give them something that would be your experience, and that allows them to feel safer. They understand now from your perspective, you're their instructor, why you're giving them this feedback, and then you link it to their goals. Remember, you said today you wanted to work on the abdominal exam. This is something that will let you get a better exam next time. So the levels of feedback, just remember the first level is that human video recorder. The second level is where you express your concern. The third level is where you give them your prediction of future outcomes based upon if they continue that behavior or if they modify it. And there's 3 good examples on the little video snips of a faculty member giving a resident some of these different feedback levels. So the real brief level 1, level 2, and level 3. The last topic that's listed on here is mid-rotation feedback, and I want to take a minute and just describe the difference between feedback and evaluation, because that question often comes up. What is that difference? So an evaluation is when you're assessing a learner's performance against some sort of standard or norm or goals for the purpose of grading or scoring. So if you say to a learner, you're in the top 10% of the students that I work with when it comes to taking a history. So that's actually an evaluation. Whenever you compare someone against a standard of some sorts, and for you that would be the students that you've worked with. That's the standard that you're comparing this person against. So if you're giving them something like that, that's an evaluation. That isn't information specifically about what they've done, how they've performed, or anything that would really allow them to move forward next time. So a lot of times you have to provide some evaluation comments, but an evaluation might happen at the midpoint where you're looking to see how are you doing reaching your goals of the rotation of the experience so far, and it certainly would happen at the end when you fill out some sort of evaluation form. It gets a little confusing because sometimes people use the term formative feedback and summative feedback. Formative feedback is your day in, day out feedback during the office visit or during rounds or during precepting with your residents. That's moving them ahead, helping them form the basis of their skills and their competencies. The summative feedback is the summation of their performance, and that's basically your evaluation. That's wrapping everything together at the end and giving them some sort of comparison to what you expected from the goals of the rotation or the goals of the institution. So you give them some sort of grade or score, and that's your summative feedback. So you'll see on the mid-rotation feedback, and putting on my hat for the accreditation, any medical school specifically that has a student rotating with you that is spending a month or more, any month or longer required clerkship has to have a mid-rotation feedback documented. The LCME, which is the accrediting body for the MD programs in the United States and Canada, requires this of any rotation 30 days or longer. So if your medical students are coming to you, and they might, saying, I need to get my mid-rotation feedback, this is an important accreditation requirement for your institutions. So again, your role in providing feedback is critical, both for the development of your learners and for the continued accreditation for the programs that they come from. It's a little different with regard to residency programs. Why would we even have to put in the idea of a mid-rotation feedback? Shouldn't they just be giving feedback all throughout and know what's going on? Well, unfortunately, some students can get just kind of lost in the shuffle, especially if it's a big rotation. Usually one-on-one with a preceptor in the office setting, that's not going to be the case. But on large rotations, they can just be kind of milling about, going through the day, maybe getting some feedback, maybe not. And at the end of the rotation, they don't know really where they stand against the goals and objectives of the rotation. And you don't want somebody to find out that they're not performing well at the very end. So at least at the midpoint, sitting down, having a more structured discussion, so you see the quick tips. It's just like that rocket hitting the target. We got to know what are the goals that we set at the beginning of the rotation or that the institution sets. What are the goals? How are the students approaching those goals? And kind of work with them to self-assess. We'll do the feedback with the techniques we just discussed, the modified feedback sandwich. Make sure they confirm things, and then if there are topics that they have to work on or you'd like to see them improve, make sure you come up with some sort of plan for them and reestablish goals for the remainder of the time they have with you. It can be fairly brief, shouldn't take very long, but it's a more structured discussion as opposed to the end of the clinic or the end of the day feedback sessions. So that's your just topics about the mid-rotation feedback. Right now there isn't any videos to reflect the mid-rotation feedback, but that may be something that's forthcoming. So lastly, on the guided tour here, I just want to click on the boot camp modules. So that's at the top under Preceptor Resources again, and that'll go to 3 specific modules. And I'm not going to click the link here because this will launch a kind of a self-advancing with audio module about feedback for learners. So it builds upon and it covers similar topics that we've just discussed in this seminar. It's an additional 1 CME AAFP credit that you can get for each of those boot camp modules, so you can get a total of 3. It takes just about 45 minutes. I went through it, and it's a very useful thing. And there's a few questions that you click on to answer at the end of that. So if somebody works primarily with residents, and I know we have a good number of folks that work with residents, there are topics about residents and difficulty, and then the standard residency precepting with some pearls, but this is generic feedback for learners, both for residents and students. So these are provided, these modules are provided with an institution subscription to Teaching Physician, so it should allow someone to get just further educational resources. I do want to put a plug in for whoever manages your CME credits at your institution. The AMA now allows if a ACGME accredited residency program or an LCME accredited medical school applies to offer CME credit for learners, they allow Category 1 AMA credit for education in preparation of teaching a student or a resident. So even other CME related kind of topics, you can get through these the AAFP credit, and you might also be able to get AMA credit if you touch base with the people who handle that at your institution. They actually have to apply and set that up. So I want to switch back briefly here to our teaching physician slides. Basically, kind of wrapping things up, knowing your role as the important person providing feedback to your learners so that they develop their skills, basically knowing the goals and objectives, what is that target, knowing your institution's goals and objectives, especially if they come from an outside institution, preparing people to receive feedback. This is all that self-preparation that we're talking about, so we have our interpersonal skills, our communication skills, the approaches to deliver this information. We build this into our learners, and we develop the culture of feedback at the institution so that people aren't scared or filled with a sense of dread when a feedback session has to begin. Assessing the learner's experience and doing that self-assessment is important. Again, we'll talk next time a little bit more detail about how to directly observe the learner, but a foundational component of this is how can I make sure I'm seeing and hearing my students in action instead of just having them come out of the room and present the case to me, and then I go back in the room and I finish things up. So that would be like the tennis coach who's hanging out at the clubhouse, and the tennis player comes back and tells you how their serve was, right? So we want to apply these skills and really work on directly observing our learners. And then finally, if we don't give some praise to encourage their strengths, they might have just done some behavior by accident. and we want to increase the likelihood that they've done something positive and they do it over and over. So yes, we have to give them praise that's genuine and specific, and we have to balance that with the criticism and the guidance so that they know how to improve next time. So I think if we look back at our learning objectives, we can list characteristics of effective feedback. If we think of that T time, we can describe techniques for delivering effective feedback. We've got that modified feedback sandwich. We've got ways of doing the human video recorder, level 1, expressing some of your concern, level 2, and then your prediction on what's likely to happen if they continue this behavior or if they modify the behavior in the future. And then identifying your web-based resources. You've got tons of resources on the Teaching Physician website, and I'll correct that little typo that's on there I just noticed. Also that links out to that boot camp modules. So we've covered a lot on our learning objectives, and we've gone through a good amount of time in the webinar now. So I would like to see if there are any questions that you can submit via the email type feature, the little chat feature, and I'd be happy to, at this point, field some questions.
Wow, Randy, this has been a great webinar. You've just packed a lot in for our participants over the last 50 or so minutes. Thank you so much.
Sure.
Let me pitch a question to you while we're waiting for questions to come in. You really went over pretty in depth, you know, the tea time and the levels of feedback. But what do you do when you have a resident or a student who just isn't responding to the feedback at all, and they're, you know, you've used the sandwich techniques, you've really paid attention to the methods you have suggested, but if they're just not responding, what do you do next?
That's a great question, and so one of the strategies is as a clinician, and if our audience you know, is filled with folks who are preceptors and clinicians, we basically have the skill set built into us in the way we approach patients who might be difficult to change their behaviors. And there is a nice module right here under the giving feedback. There's a nice article, that says, what about that difficult feedback for the problem learner? And this little article describes a way for you to identify, so what do you think the problem is? It's kind of like doing your diagnosis. So just like when we're dealing with a clinical problem, what's the learning problem for this person? Can we compartmentalize this to a knowledge-based issue where, you know, we've given them feedback and they come back the next time and it's just clear that they haven't read up on things? Maybe is it a motivation issue? So they're not interested in this specialty or that we work in, or, you know, they've got something else on their mind that's just not motivating them to do the work. Is it a behavior issue? Do they have, you know, some personality issue that they just don't interface well with certain types of patients? So we use our clinical skills to assess the learner's issues, and then we try to address those things with them and give them pointers about ways to change. Sometimes, as a preceptor, when it's a difficult learner like this, you want to elicit the help of your clerkship directors, sometimes the medical school, the dean of medical education is a good resource, but it really does make it more difficult when you've got someone you're giving feedback to, and it's very important to document what you've given them and being specific, and then they just keep showing the same behavior over and over. You do what you can, you document what you can, and then you kind of go up to the next level and you work with the clerkship director or sometimes the dean of the medical education, assuming this is not a stop the presses professionalism problem where you basically have to, you know, cease the student's involvement with patient care. That's rare, fortunately, that ever has to happen. Sometimes that does happen. And you directly contact the medical school or the clerkship director with any of those concerns.
All right. Well, I think we do have a question, Dr. Clinch. How do you untrain behaviors from a separate medical culture that were instilled in prior training? I think that's a good good question. I don't know if you can.
That is. So being putting on my residency hat, you know, not every resident that comes into our setting were trained in our medical school. So I'm very familiar with the training that our students get, and upon graduation, if they become a resident in our program, I know what they've been trained. And they really can't come to me and say, well, you didn't teach me that, or I was taught this way. But as residency faculty or as community preceptors, we get folks that were trained in a variety of different ways. So basically what it kind of hits two major points that we've covered. Number one, figuring out what is the goal of the experience that you're dealing with for today. So for example, if the person you're working with says, I really want to work on development of a differential diagnosis, or I really want to work on my eye exam, or I really want to work on common antibiotics. So have some specific teaching goals so that you know what your learner's trying to do and you know what you're trying to assess for them. And then the way they approach those goals, since they may have been trained a little differently than you may have been trained, if it isn't counterproductive, then that's the variety of experiences they can apply to the way they approach things. If it's counterproductive, then it's up to you to let them know why it's counterproductive. One of the problems is students who become residents may or may not have received adequate feedback, or they may have received feedback that was very good by one person but by no one else. And then they empirically develop their own sense of competency and worth, and they're less likely to believe what somebody else tells them, even though it might be very appropriate. So if you basically notice that there's a counterproductive way that this person is functioning or approaching something, you go through that same level 1, here's what I saw you do, level 2, here's my concern about things, and level 3, here's what I think you're going to get differently if you change this behavior. So all you can do is kind of give them your guidance, and if you still see that they aren't making any changes to something that you feel is a counterproductive behavior, usually it's not a technical skill, but it's a behavior. You document that, you let that go. If you need to, you contact their residency program director, you work with their advisor, you work with the medical school. But if it's really disturbing to you about some aspect, again, go back to the medical school, or you work with that person's advisor. All you can do is give them your best advice about the likely outcome of that continued counterproductive behavior. Hopefully that's helpful.
Great question and a great answer. We've got one more question, and we just have a couple of minutes, so I'll pitch it to you. Sure. May we assume that giving feedback and evaluation to faculty uses the same template, or are there other specifics not only to methods but also to timing? And I guess the question really is, instead of feedback to students and residents, are the feedback guidelines to fellow faculty also applicable based on what you've shared today?
Right, so that's a really good question. And so the template and approach to just the delivery and the interpersonal skills is the same. If it's a peer-to-peer discussion, faculty member to faculty member, same level of whatever, professorship, or same level in the residency department, or colleague in the office, you know that you have to be attentive to your relationship with that person. So it's just a lot to do with the interpersonal way you deliver the message, how it's then received. But yes, the same issue. So what's this? Why are we doing this faculty feedback? Am I in a position of a job review or something like that? What was the goal? So if it's about my delivery of feedback to our residents by my program director, I'll want to hear what my residents have said about things, and so my residency director will tell me, it's been reported to me that when you deliver feedback, this and this and this occurs, or the residents do or don't appreciate this, this, and this, and then find out what my take is on it, work towards a more productive behavior, set a time to reevaluate. So same steps, exactly same steps.
Okay, terrific. Well, we are really out of time. Thank you, Randy. You did a great job today. You packed a lot in for our participants. And thanks to everybody for joining our webinar, our third webinar on precepting and teaching position. Again, at the end of the webinar, you'll receive an evaluation in your email. We hope you'll take a few minutes to complete it and send it back to us. We want to hear from you about how we can improve our webinars in the future. And as I mentioned earlier, you can apply for up to 1 CME credit by going to the bottom of the evaluation, and that'll link you to the AAFP site where you can self-report for your CME credit. Finally, we hope you'll join us for our next webinar scheduled on Thursday, September the 5th from noon until 1 p.m. Central Standard Time. The topic will be tips on direct observation, and the webinar will again be led by Dr. Clinch from Wake Forest and his colleague, Dr. Scott Harper. Please check the STFM website for a complete schedule of the final 3 webinars or to sign up for one of these as well. Just go to the site at www.stfm.org and scroll to the bottom of the site, and you'll see our teaching physician webinar series link, where you can get much more information about this series. Thank you so much, Dr. Clinch, and to everybody for participating today, and we look forward to seeing you next time. Have a great rest of the day.
Thank you.